Hello, everyone. Thank you for joining us for today's discussion on leveraging county systems to support infant and toddler mental health and well-being. My name is Dr. Lee Johnson III, and I am Senior Policy Analyst with 0 to 3. I will be serving as the moderator for today's webinar. Welcome. Thank you for joining us. I'm very excited to join this discussion with local leaders in South Dakota and Texas who will be sharing how they are connecting parents and young children with the social and emotional supports they need. But before we begin, I'd like to cover a few logistical items. All attendees have automatically been placed on mute. If you have a question for our speakers, please share it using the Q&A function at the bottom of your screen. If you would like to share comments, reactions, or resources, feel free to share those using the chat. We are recording this webinar and will share the recording and slide deck with attendees on the NACo website. Next slide, please. Today's webinar is part of the Counties for Kids initiative. Counties for Kids is a public awareness campaign for county leaders who are committed to making investments in young children from prenatal to age 3. Counties for Kids has free online tools and resources available for all counties, no matter where you are in your early childhood journey. You can find these resources and more at countiesforkids.org. Now, I will begin today's session with an introduction to infant and early childhood mental health and the work 0 to 3 has done on this topic. We will then hear from Dr. Stacy Bourne, who you see on this slide, with South Dakota State University, and Brooke Sun with the Office of Children's Services in Travis County, Texas. Following the presentations, I will lead our speakers in a facilitated discussion before opening it up for your questions. All right, next slide, please. So I'd like to take this time, as I've shared, to share a little bit about 0 to 3. So thank you again for everyone taking part in today's webinar. I want to give a special thanks to Rashida Brown, to Arabella Pluta-Ehlers, and to several individuals whose contributions have made this webinar possible. I would also like to acknowledge all of you joining us today, near and far. I could see from looking at the chat, some of you joining us I've known for just a little while, and some of you I've known through correspondence for many years. I'm mindful of the variety of feelings, the variety of blessings which you bring to this moment, and I'm grateful to be with you. As I've shared, I work at 0 to 3, and I have the marvelous privilege of talking about infant and early childhood mental health, or what I like to refer to as setting the stage. And while I'll be setting the stage about development, I will also be setting the stage for today's discussion. I say setting the stage because that is exactly what early relationships do, set the stage for later development. Next slide, please. At 0 to 3, we envision a society that has the knowledge and will to support all infants and toddlers in reaching their full potential. Next slide. And in this moment of stage setting and thinking of early relationships, I'm incredibly proud to represent 0 to 3 today, who is committed at being an ever-present and reliable force for keeping babies at the center of our work. And continuously strengthening our relationships, connections with you, and all the professionals working to ensure babies and toddlers have a strong start in life. Though in speaking of at the center, when I think of babies, I think of the preschool children they soon become. I think about the teenagers that grow up to be, and the adults who walk among us navigating this wide, wondrous thing human existence is. Many of these adults are caregivers, much like the ones that you see in the graphic of the picture on the slide, with obvious delight. And other adults make up the village that surround young people, like all of you. So again, I want to give a special thank you for all the work you all do, especially with all that is going on in the world. Next slide, please. To some, it may be hard to imagine what mental health problems look like for infants and toddlers. But like any person, young children experience a range of emotions and react and recall situations in unique and dynamic ways. However, when our US mental health system was shaped, history tells us that babies' unique needs were neither recognized nor considered. We now know babies can and do face mental health challenges and can be best equipped to thrive when they have what they need to thrive. 0 to 3's Policy Center framework, with the aim of ensuring a strong start for infants and toddlers, promotes good health, strong families, and positive early learning experiences for all infants and toddlers, with special emphasis on those who are the most vulnerable and in need. What I often share with congressional staffers on the Hill is that there are many factors at the child, family, community, and societal levels that can contribute to the mental health difficulties infants and young children experience, whether it's medical and developmental disorders, exposure to adversity, trauma from natural disasters, or witnessing violence. And the chronic stress of poverty can influence how babies feel and their mental health now and into the future. However, when I talk about the interplay of these factors, I make it an important piece of the conversation to talk first about the science of brain development. Next slide, please. And so, in keeping with this theme of setting the stage, 21st century science is clear that all brain function that sets the stage for later development is a direct result of an interaction between genetics and the environment. And brain science explains for us why the first 1,000 days of life matters so much for children's development. With 85% of the brain developed by the age of 3, 92% developed by the age of 5, what this shows is that brains are being built during this critical time of growth. And the first 5 years lay the foundation for everything that follows. And that foundation can be sturdy or fragile, as I'm sure all of you are aware, depending on a child's experiences and even more, their environment. Next slide, please. However, when I look at this picture in the previous slide charting brain development, I think about my own life and have become acutely aware that childhood is not an adventure we choose, but it is chosen by adults familiar and forever unknown through the experiences they create for us. So whenever I look at these photos, I will never forget the sense of wholeness I felt when I finally realized what in fact I really was. Not just an early childhood educator or state director or a student of human development or a policy analyst, but I was someone who experienced both positive and negative things throughout childhood and into adulthood, and someone who would later use every single talent that I had ever been given to me in the service of children and families. I can tell you that it was that particular focus that made all the difference. I can also tell you that none of that was written on the back of my college diploma. Um, it's a miracle when we finally discover whom we're best equipped to serve, perhaps from those early positive experiences, where we can also best appreciate the unique life we've been given. And that profound discovery came through my early relationships and development. Next slide, please. And so, a major premise in supporting early brain development and the relationships that foster development is a concept I like to refer to as one that sits at the intersection of all things child well being, which is infant and early childhood mental health, which is defined as the developing capacity of a child birth to age 5 to experience, to express, and regulate their emotions, to form close and secure attachment relationships, and to explore their environment and learn, all within the context of family and the community. I'd like to acknowledge that we often use the terms infant and early childhood mental health and healthy social emotional development interchangeably. But I would also be remiss not to mention that very young children can and do experience serious early childhood mental health challenges, with children ages 0 to 5 experiencing at least one social, relational, or behavioral health disturbance during their growth and development. Next slide, please. And so one of the wonderful things about this webinar is an opportunity to highlight all the ways we can promote social and emotional well-being. And in my role, my work falls primarily in the policy space, as you can see on the graphic on this slide. And there are others here that have joined us from across the US whose work touches children's lives from other avenues of connection. And I wouldn't be surprised if there are some areas on this particular graphic where you are familiar with in your work. Next slide, please. As I shared on the previous slide, my work falls primarily in the policy space, though I wanted to offer a variety of ways to define policy here and how we in our infant and early childhood mental health policy team talk about it. So I won't read off the slide, but we often talk about it in terms of little p policy, where I'm analyzing legislation or talking to administrators about programmatic policy. And then of course there's big P policy, which involves legislation on the city, county, state, and federal levels. Next slide, please. Our country has undergone quite a few changes, experiences and impacts from presidential to congressional to folks navigating a pandemic with or without loved ones. And one of the administration's highest priorities must be to meaningfully support the health and well-being of babies, families, and communities through robust investments in health promotion and prevention. And we know with ongoing conversations about mental health in Congress and the administration, it is important to highlight effective ways to make wide-reaching and long-lasting change that ensures families can thrive. Said differently, any reimagining of the US mental health and behavioral health system must have its roots in services that start at birth. So I've laid out on the slide just an overview and a quick look at 0 to 3's perinatal and infant and early childhood federal policy agenda. And again, I won't read off of the slide out of respect for the time that we have today. But as you can see, there are significant policy areas that would be most important in ensuring that families have what they need to thrive. Next slide, please. And much like the 3 areas, we've dug quite deeply at 0 to 3 on these priorities, specifically increasing the size, diversity, and quality of the clinical workforce. And as you know, there are more layers with the workforce discussion that we can dive into. But again, just wanting to highlight here that we have been discussing this with more than 40 contributors, ranging from funders to current students to early career clinicians, employers. And again, this is by no means an exhaustive picture or solution guide to the workforce challenge, but is really a starting point for a conversation. Next slide, please. We know that the president has actually released his budget as of today, but wanted to provide a snapshot of what we mean when we talk about expanding systems, building capacity, and increasing access to high quality services. And again, you all will get access to these slides, but wanting to provide a snapshot here. Next slide, please. And then of course, expanding data and research capacity is dependent upon many of the strategies that we use in the work that we do on the Hill, be it providing education, translating science, or mobilizing the field of leaders who have an understanding of the mental health needs in their state, who also understand the mental health system in their state as well, to be able to leverage their expertise to ensure that babies thrive. Next slide, please. And then of course, cultivating champions. I've laid here just some considerations for all of you to think about if you are beginning discussions in your state or continuing discussions in your state about how best to support the infant and early childhood mental health needs of children in your communities. Next slide. And then lastly, I would be remiss not to mention that if you would like to get involved, you may sign up at www.thinkbabies.org to find additional information as well as stay up to date on policy efforts that I and my colleagues have engaged in. Next slide. And then here are just a handful of additional resources some of you will be able to utilize in your work to have a deeper dive on specific themes. And so that concludes my presentation. Again, as a reminder, if you have questions, you can share them using the Zoom Q&A function. But right now, I'm pleased to introduce our speakers. Joining us, next slide, from South Dakota State University, thank you so much, is Dr. Stacy Bourne. Dr. Bourne is an assistant professor of counseling in the Department of Counseling and Human Resource Development at South Dakota State University. Dr. Bourne coordinates and advises the marriage and family counseling and play therapy specializations. She is also the Workforce Development Director for the South Dakota Early Childhood Mental Health Collaborative, a SAMHSA-funded 5-year project targeted at improving the status of early childhood mental health across South Dakota. We will also hear from Brooke Sun with the Office of Children's Services in Travis County, Texas. The Office of Children's Services is dedicated to policy development and coordination of service delivery for Travis County Health and Human Services, direct services, grant-funded efforts, and contracted community services for children, youth, and their families. Brooke has extensive early childhood experience and oversees the county's Family Drug Court, which has a strong emphasis on infant mental health and services to the 0 to 3 population. Thank you both for being here today. I will now turn it over to Dr. Bourne for her presentation.
Great. Thank you, Dr. Johnson, so much. I'm really excited to have the opportunity to be here today and to share some of the wonderful work that is happening in South Dakota. Let's go to the next slide, please. I think really to lay the framework, what would be most helpful is to draw a picture quite literally of the map of South Dakota, just to let you know a little bit about some of the barriers and some of the opportunities that we've faced. So South Dakota is a unique state in that we have 2 population centers, Sioux Falls, which is in the southeast corner of our state at about 193,000, and Rapid City, which is on the west side of our state, has a population of about 75,000. The total population of South Dakota is just under 900,000 individuals, which we have the common sort of story to tell that there's actually more pigs in the state of South Dakota, the livestock pigs, than there are humans. And so sometimes gaining access to services and things that help support humans in our state is a little bit of a barrier, but we have made some tremendous progress, and I'm happy to share that with you today. Another unique feature of South Dakota, which I'm guessing some of you today are logging in from rural and frontier states, is that not only do we have our metropolitan population islands, but we have throughout the state a few other population islands. And so therefore, to get from one part of the state to another to maybe access early intervention services or things can be a challenge or a barrier for families, as it might require them to travel 2 to 4 hours. And we know that there can be a lot of logistics in terms of helping very young families access some of those resources. We're also proudly home to 9 federally recognized tribal communities within South Dakota, which greatly impacts and informs the work that we do across our state, especially as it's related to early childhood mental health. All right, next slide, please. So how it all started, as Dr. Johnson mentioned, we are a part of a federally funded grant program through SAMHSA. And in June of 2018, a partnership was formed between South Dakota State University, which is a land grant institution, there is a land grant institution in every state across the nation. I think that's important to highlight because being affiliated with the land grant institution allowed access for our partners to our extension offices, which are located across the state of South Dakota as well. SDSU is partnered with Southeastern Behavioral Healthcare, which is a community mental health center within South Dakota. Now, again, every state also has community mental health centers. How they are designed and structured is specific based on your state. However, those are also really helpful partners and access points for doing some of this important work. In addition, we partnered with Interlakes Community Action Partnership, which is our sort of catchment area on the east side of the state, and they provide the Head Start classrooms for children ages 3 to 5, and then they also have several classrooms in the birth to 3 area as well. Essentially, though, our 3 groups came together, passionate about children's mental health and wanting to get something started. And so thankfully, we were able to apply for in 2018 and were awarded later that year funding that provided over $2 million to initiate some of the early childhood mental health workforce and service needs necessary in our state. Next slide, please. Our South Dakota Early Childhood Mental Health Collaborative has 3 basic goals. Lots of activities under each goal, but I'll just highlight these 3 for us today. The first goal, and this is probably most strongly reflected in our work with our Head Start partner, is to increase developmental screening, referrals, and assessment overall of social emotional learning. What we've been able to do is partner with our Head Start partner, help them develop a social emotional learning strategic plan, help them implement a new social emotional learning curriculum that they felt better reflected the needs of their communities and the philosophy of their center. And then also to better develop measures and systems for accessing, what do I do with the social emotional data once I collect it and learn about it from my particular classroom. In addition, based on that social emotional screening information, we're able to provide access to services offered through our partner, Southeastern Behavioral Healthcare. So if children or families are in need of mental health services, family services, or perhaps play therapy, we're able to make that smooth connection and transition. Our second goal, which is really important for South Dakota, was to increase the workforce. One of the reasons that Southeastern and our Head Start partner came together with SDSU is we had a big workforce gap, and we had to find a way to begin to address this workforce gap so we could better serve our youngest community members. And so our second goal highlights all of the different programs, training opportunities, and systems we have put into place to increase our early childhood mental health workforce. And thirdly, our goal is to increase access to that workforce, to that particular play therapy service. And we've been able to do so not only within our community of Sioux Falls, where Southeastern Behavioral Health is located, but across the state of South Dakota as well. Next slide, please. For today, I'd just like to highlight the workforce development work that we've been able to do. So we are halfway through our 4th year of 5 years with the South Dakota Early Childhood Mental Health Collaborative. And when it comes to the workforce, we've been able to train more than 1,000 professionals. They've either attended one of the activities that are highlighted below. You can see sort of what we've depicted here for you is that there are sort of population centers, and you can see that we've made a really concerted effort to not only train where we are more heavily populated, but to be really conscientious about spreading that information across our state. Because one of the things that we've learned, and I can say this, I guess, as an academic professional, is that what can be tremendously difficult is to train the workforce and then send them to a community that they are less familiar with to do the work. Now, that is definitely possible, but perhaps one of the more facilitative ways to deliver the workforce is to attract those who are from those rural or remote communities to pursue advanced training or advanced knowledge so they can bring that information back to their communities. That tends to be a very strategic and helpful tool for us. Next slide. There's quite a bit of content here, and you will have access to the slide deck. I just want to highlight some of the workforce development activities that we have done. The largest probably being working from our play therapy training program at SDSU. It was established in 2017, and it allows us to train individuals in a developmentally informed, trauma-informed, and caregiver-emphasized therapeutic modality, where we're not only serving the child, but we're also serving the caregiver with what are some particular tools that are going to help you and your child perhaps be more successful or develop stronger mental health. The credential as a registered play therapist is housed within the Association for Play Therapy, but most importantly, it's a specialty training that folks who are already licensed as mental health professionals are able to obtain. Next slide, please. As a result, we've been able to train and have registered over 30 professionals as registered play therapists within South Dakota. Prior to our efforts, there were less than 10 play therapists in South Dakota, so having almost tripled that number is incredibly exciting. In addition, because of the increase in play therapists, you can see that our, on the bottom here, our South Dakota Early Childhood Mental Health Collaborative, our clinicians within Southeastern Behavioral Healthcare have been able to serve an increasing number of children as a result too. Next slide, please. Another important aspect of workforce development was training in the DCO-5. The DCO-5 is the Diagnostic and Classification Manual of Developmental Disorders of Infancy and Early Childhood. And what this manual has been incredibly important for our mental health workforce is understanding how do we particularly conceptualize and treat some of the disorders that might be present in very young children. And the special feature of this tool is that it classifies the mental health difficulties that someone might experience with the consideration of those primary relationships that the child encounters on a daily basis, from childcare environments to caregiving environments, and important community and cultural factors too. Next slide, please. Another aspect that we've provided for our mental health workforce is training in TheraPlay, which is a trauma-informed, attachment-based therapeutic modality that works at repairing ruptures between the caregiving dyad, again, to improve those later mental health outcomes in children, because we know that attachment relationship and caregiving relationship is important. Next slide, please. So some key things to think about in terms of sustaining our efforts is that we have been largely successful because of those leaders from the organizations that came together. We collaborated, we trusted, and we communicated. Much of what we wanted to achieve, we have been able to achieve, but our communication and honesty has been really important so we can be flexible, meet the needs of our communities as they begin to emerge or become more clear through the work that we've done. Additionally, developing the workforce that's rooted in the systemic and culturally informed caregiver approaches was incredibly important. It wouldn't be ethical for a clinician to work with a child for 1 hour a week and send that child back to the system of care without also addressing the important needs of the systems of care that children are embedded within. We've also, again, had to be really thoughtful about developing our local workforce. And as we head into year 5, we're really spending some focused effort on legislative advocacy. And that legislative advocacy not only was necessary for us to get our program off of the ground and running, it was some important legislative advocacy and support that allowed, I think, our grant to be funded. But it's also been our ongoing partnerships with our child protective services, with our state legislature and our champions in early childhood mental health, and really being able to increase that access and also that knowledge as to what infant early childhood mental health truly is. All right, and with that, that wraps up my content for today. I'm going to hand off next to our next speaker, Brooks Sun. Brooks Sun, thank you.
Hi, I'm Brooks Sun, and I will just be speaking to you with no slides today. So, as Dr. Johnson mentioned, I'm from Travis County and in the Health and Human Services Department, specifically in the Office of Children's Services. Travis County is in Central Texas. Austin is our major metropolis here in Travis County. We are one of the smaller urban communities in Texas, but definitely growing. Maybe you have heard about Austin growing. We're a really growing community. I am the Prevention and Intervention Manager in the Office of Children's Services, and I'm going to talk to you about a couple of our programs that do have a very specific focus on that first 1,000 days. I have been in this role since 2017. Before that, I worked for Travis County in the Research and Planning Division. I was a senior planner there with a focus on early childhood. And I had the pleasure when I was in research and planning of working with our incredibly robust advocacy community for early childhood education and development. There are a lot of experts in Travis County that understand and work hard to make sure that we have a great system of services that address early childhood education and early childhood and infant mental health. So in the Office of Children's Services, we have two programs that we have a number of programs and services, but two programs that really specifically focus on that. early childhood mental health piece, one of which I oversee. It's a family drug court. It's called Parenting in Recovery. And it is a joint effort across several county departments, including our civil courts, the Office of Child Representation, and Health and Human Services, and the District Attorney's Office. So we work together across our departments as a county to ensure that there are services in place that can legally support the families we serve, because they are all engaged in a legal case with Child Protective Services. And then we can provide a very robust set of services, human services, to support those families in their time. All of our families, as I mentioned, are CPS involved. The primary issue for all of our families referred is substance use disorder, and the cases typically start as a result of substance use disorder. So many of our families are moms who have drug positive births that are identified in the hospital, but that's not the only kind of referral we get. So these are lawsuits filed by the county or by the district attorney. So families are engaged in a CPS case, and then are usually in our program for about a year and a half, and while their CPS case is ongoing. So they're having regular court hearings, and we are providing a very robust set of wraparound services to those families as they are engaged in that case. As I mentioned, we have those county departments. We also have 10 other chartered partners, service partners from across the community, including treatment providers, other kinds of recovery supports, our local mental health authority, housing support. So many other community nonprofits come together with us to ensure that we have a full array of services to support those families. This program started in around 2008. We enrolled in its inception. Then there was a lot of work in the community to build it and get it ready, and we enrolled our first participants in 2013. We have grown quite a bit since then. The focus on the early childhood and the infant mental health piece of this program really came into full being in around 2015. We hired 2 dedicated child and family therapists to be assigned to each family on our caseload. So every family that we serve has a therapist dedicated to the mental health of the children in the case. One of the criteria for our program is that there's at least 1 child under the age of 5. But typically our families have an infant, at least 1 infant. Some have many other children in addition to that. So the scale of our program now is much bigger than it was when it started. In 2022, we served 80 adults and 117 children, which is quite a bit bigger than it was when we launched it in 2013. We're growing and expanding and trying to serve all the families that are eligible in our community. So we are a little bit different than a lot of the family drug courts that you might encounter across the country, in that we have the structure of our legal cases is such that parents maintain custody of their children. So there is no period of child separation. That is the core of where our infant mental health concept resides, is just avoiding the trauma of family separation to begin with when we can. That starts with a 90-day stay in a substance use treatment facility, residential treatment facility, where mom and the youngest child, at least, sometimes multiple children, can attend treatment together. So there is a full child service component to those substance use disorder treatment programs, while mom is getting a full dose of 90-day substance use disorder treatment. We do also serve fathers. We serve families, but their fathers are typically served in another kind of residential treatment program, and then the families reunify, and all can live together at a later point in our program. So that's where it starts. It starts with 90 days of residential treatment, and then we have another 90 days of sober living where moms can continue to live with their children in robust recovery supported programming, and then transition from there after that second 90 days into the remainder of their program, which is an independent, they live independently but continue to have that robust set of services. So the supports given to those families include the child and family therapists who are there to individualize the services and care to every single family that they support, including mental health supports, ensuring the parents have the mental health and recovery supports that they need, and then are able to focus on that very critical bond between parent and child. They're doing screenings with developmental screenings with children and ensuring those children have access to any of the early childhood supports needed. They use a range of evidence-based supports, including nurturing parenting. They do both of our family therapists are served in the nurturing parenting curriculum. They both are trained in trust-based relational intervention. They both are trained in play therapy, so they can manage and address therapeutic needs in a wide number of ways, and definitely do. So yeah, that is our family drug court program. I recently heard about a court curriculum or another kind of court program called 0 to 3. And it does sound like they are doing something that would integrate really beautifully with our program. We're doing a lot of it now, but there is a 0 to 3 court program that is being implemented nationally that is, I think, doing incredible things for families with young children engaged in CPS cases. So changing gears, Healthy Families is not a program I oversee, but it's a program I'm very familiar with because of my time in serving as a senior planner in the research and planning division. I learned quite a bit about this program. It is an accredited home visiting program. It is a 3-year program that starts prenatally and serves families until that child is close to age 3. Healthy Families Travis County has been accredited by Healthy Families America since 2004. They screen at this point in the program's evolution. They are screening about 100 families per year, and then enrolling for that full 3-year period about 80 families per year. The goals of Healthy Families includes to reduce childhood maltreatment, improve parent-child interactions, and overall child social and emotional well-being, increase school readiness, promote healthy development and positive parenting, ease access to medical care and other community resources. Is that my time? Am I going over? I'm seeing. Okay. In their home visiting, they provide all kinds of services, including safety supports and supplies, car seat training, evidence-based parenting curriculum, which is the core of Healthy Families, child development assessments and educational materials, and breastfeeding supplies and immunization access, all kinds of things. They are culturally responsive and bilingual in the services they provide. So, Healthy Families.
Thank you so much. And again, I imagine you could sense the feeling of not wanting to jump in while you're talking about the impact of these incredible programs and the work that you're doing. And I know that time is getting away from us. But I want to thank you, Brooke, and I want to thank Dr. Bourne for sharing the exciting work that is happening in your communities. As a reminder, if you have questions, if you would like to share your question with the presenters, you can share them using the Q&A function at the bottom of the Zoom. And we will have time for audience questions, hopefully at the end of the session, but we really want to start in on the discussion. And I've been, it's just a joy to listen to you both about the work that you've been engaged in. And thank you, Brooke, for mentioning the Safe Babies Court team. As you shared, I could see from looking in the chat that there are colleagues of ours near and far who are familiar with the work of the Safe Babies Court team. And of course, as you mentioned, it harnesses the science of child development to drive change, that it contributes to building state and local systems that support a range of comprehensive trauma-informed infant, toddler, and family services for families in the child welfare system, and where possible, those in need of preventive services. So I really thank you for highlighting that and speaking most importantly to the need for keeping families together. So some of the questions I have outlined for you will kind of get a little bit more at some of the things that you've been seeing in the work that you've been doing. And so I want to open up the first question to either one of you that feel most compelled to respond first. But the first question is, can you speak to some of the primary challenges that families in your county have experienced in the last few years? And so I will pause here to give you an opportunity to decide amongst yourself who would like to go first. But happy to hear from both of you.
I'm okay are you okay, Brooke? I'll take that up first. Great. So obviously there's been a tremendous amount of challenges for families in the last few years. Statewide, some of the things that we see really impacting appropriate daycare options for children who might have difficult behaviors, especially in a childcare environment. Perhaps the childcare environment is still working to make adjustments to the environment or to the care that they're providing. However, sometimes that results in a parent needing to leave work to pick up a child. So that we can begin to see how that the caregiving environment can have an impact on mom or dad's ability to be able to maintain employment or satisfaction with their employment. And sometimes parents have had to leave their employment because they need to pick up their child or find alternative care. The other more unfortunate side of that too is parents having to access care they maybe aren't fully comfortable with because of a lack of care for their children as well. I think in addition to that, just being in our rural and frontier state, having access to providers who have training in developmentally informed, relationally based interventions has been something that we've really targeted and we've made progress on. And we also have the opportunity to make more progress too.
Yeah, I can echo the issue of childcare access is a really significant one for our families. COVID is, I think, a huge culprit. It was a strange system, as we all in the early childhood world know. Has been a strange system for a very long time, and I think COVID really did just knock the legs out from under that system. And so we have a lot of families who just aren't able to access childcare and have small children, sometimes multiple small children in their care, while they are trying to do very, very intensive therapeutic work, which has been happening largely at home. So they're trying to do this therapeutic work at home with small children in their care. It's been really hard to sort how to do that. I think that we are coming up with some solutions, but that has been a really big challenge for us, and how much we can require parents to go deeply into this therapeutic work that we're asking them to do in this program while they're holding their babies on their laps. And then housing is just an eternal issue for us, and it has become an even more serious issue as we continue to grow as a community in our affordable parts of our town. are increasingly gentrified, there are just fewer and fewer places, affordable housing opportunities for our families as they try to move into these self-supported lifestyles. I also can say our Healthy Families team has worked tirelessly to stay engaged with their families on a virtual platform. It has been such a hard road for them, I know, and they've worked really hard to stay connected, but it's so much about the bond of that home visitor for that 3-year period with those families, and that has been really hard. It has been a really hard thing, and they are so excited to go back to work with their families in person.
Thank you so much for your thoughts and feedback on that. And I would say, to add, I can only imagine for families who have experienced what I characterize as a very difficult challenge that comes with evictions, that comes with homelessness, that comes with housing instability. And so I'm curious, as you are thinking about how your services can, in a sense, be a bit of a safety net for families who are navigating these challenges with very young children in their care. I'm curious to know, for counties that would be beginning this work, what would you say that they need to have at the table to begin talking about in context the kinds of challenges that families are facing, but also the need to bring the kinds of services that you've all mentioned to them?
Should I go first? I'll go first again. Let's keep this going. I'll speak specifically to our unique, I think, landscape, literally and metaphorically. What's helped our program be tremendously successful is the partnership with the land-grant university, especially with the depth of needs for training in, again, the trauma-informed evidence-based approach. That has also helped us with grant management, which has an important aspect of it when you're utilizing funding that's supporting multiple entities as well. And then I think another important thing is identify your champions. Identify those who are willing to have collaborative conversations, unifying conversations, reduce the silos, and build connections, because likely there are some active and moving programs, and to partner with the active and moving programs who are also passionate about mental health has helped us get our project up and off the ground.
I wonder, I know I have at least a few colleagues here who probably can speak with more expertise about what it would take to collaborate in our county, in NACo County, trying to get this started. But I can say a couple of things. I do think that having a grants management function within the county system is extremely helpful. Having that a neutrally positioned manager of a grant that can help manage on behalf of a collaborative system is extremely helpful. And plus, you know, in addition, more county supports in terms of human bodies that can help navigate and manage some of the system coordination, including service coordination and understanding the community conditions and the landscape of the community. Having real people dedicated to doing those functions as a county is very important. I know that becomes more complicated in rural and smaller counties that don't have as much resource. And then having the voices of community leaders. Yes, champions are really important, but leadership across other issue areas that are willing to come in and talk about housing barriers, that are willing to come in and be a voice that is willing to apply thinking to the issue of families with young children and infant mental health outside of their own expertise, but apply efforts in that area. So yeah, reducing silos. I guess I'm echoing what Dr. Bourne is saying.
Thank you so much for your thoughts. And feedback. I would also echo and agree. I can not overstate how important it is to have individuals who are willing to collaborate. And I appreciate the point that you raised, Brooke, about individuals that have a place of neutrality when they are working in these programs. I think that is important um, for the children that will be served as a result of the collaborations, as well as when you're thinking about grant management and funding that stretches across a variety of different geographic regions, that stretches across a variety of different ethnicities and backgrounds, and that is so important. Um, and so to that end, as I think about grant management, for those of you who are familiar with the lovely process of grant writing, I'm sure that you know the importance of collecting data. I saw at the beginning of Dr. Bourne's presentation kind of an overview of the demographics and thinking about how that is considered when it comes to um, having a landscape of what you are navigating and working with in terms of the work that you will be engaged in. And so I'm curious about how you all have been collecting data as well as tracking outcomes for the children and families that you are serving. And then if so, could you speak to how you're collecting this data? And then, and if you are using any new or existing data systems, could you also speak a bit to that as well?
I can speak to that a little bit. So the data that we collect, obviously we support our Head Start partner in their utilization of the DECA P2. It's a strengths-based assessment of the one we use is a preschool tool for their social emotional well-being. We appreciate that not only does it measure behavioral concerns, but it measures important resilience factors that really allow us to say, hey, we have some skills here, let's emphasize this, but we also have the opportunity to build resilience in this child. And that doesn't always mean that their scores indicate that they need a therapeutic service. We're able to make classroom adjustments. Teachers are able to note that, hey, this child has some resilience strengths and some resilience opportunities and use those for each individual child as well as on the classroom level. We also measure children's behaviors through the CBCL, the child behavior checklist, and then lots and lots of satisfaction surveys I can speak to on the workforce development side. That's really important to know how are people using this information, how was the information conveyed to them, and then following up with, are we using this in practice and how is it being used and what additional resources do you need that ongoing consultation to?
Travis County is a very data heavy county. We do a lot of data collection and a lot of data analysis and reporting. My colleague Annalisa Conlon, who's here on the call, is a part of a team that does a community conditions analysis and does a whole lot of analysis of our programs that we contract with. So we do a lot of data collection and management. For the Office of Children's Services in particular, we manage multiple data systems across our programs, which can become quite cumbersome and complicated. And a lot of our data we still manage manually. Our program data we still manage manually through spreadsheets. I think that it is important to, this kind of goes back to something I meant to say in the response to your first question or your second question about what does it take to get this off the ground. I do think that is about data agreements and data management. That's a really important part of that piece of it. And that's what I mean by bodies, like human bodies who are willing to do that work, including identifying what the outputs of your effort are and counting them for you. Like, make sure that we have agreed on how and where you're going to count them, identify a set of outcomes that you're going to agree to track, and then track those. That's a really, write down what you're doing, I guess is what I'm saying. Have somebody there to write down what you've agreed to do and track data. And I think data systems are great when you can have them, but a lot of this stuff is operating on a scale where you can just agree to keep it manually and reshare and report on it regularly within your collaborative group so that you know you're all focused on the same thing. And then I want to say one more thing about the grants management part. I think when you are starting, it can be really great to identify, go for, and manage grants and have those grants in place and then build some success. Then you can turn to your county and say, hey, county, look at how great we are. It's time for us to fund this locally, and you have some data. And usually those grants that you have been funded by have helped you accumulate a story of success that you can then take back to your local champions and hopefully your local government and ask for local dollars that way after you have some experience and success.
Awesome. Thank you so much, both of you. And I will turn it over to Arabella.
Thank you, Dr. Johnson, and thank you to everyone who joined. We're almost at time, so just wanted to say a few things before we close out. First of all, thank you to Dr. Johnson and our panelists for sharing their time and their expertise. I also want to thank the Pritzker Children's Initiative for their partnership and support of our work here at the National Association of Counties Research Foundation. As a reminder, we will be sharing the slide deck and the recording from today's session. You should get those later this week. I also would like to share a survey that we ask that you just take a few minutes to complete to share your feedback about today's session. There's also a spot to share any questions you have that didn't get answered or indicate that you'd like to follow up with one of our panelists. I know that we, could do a whole other hour continuing this conversation. So please use that survey to connect with us and keep this conversation going. And again, just encourage you all to check out Counties for Kids to learn more about the work that we're doing for counties and children prenatal to 3. So thank you again and have a great rest of your day.